I asked all the panelists to prepare some cases for us that they felt were interesting, and the cases are about two themes which are continuously discussed, I think, when you do endoscopic frontal sinus surgery, and that is, does this have to be operated? And if the answer is yes, what is the best approach? So I will ask one by one all the panelists to present one of the cases, and then the rest of the panel will comment. But it would be so nice if you participated in that discussion. So there are microphones around, so whenever you think I fully disagree or I really don't understand what he's saying, that's also possible, raise your hand and someone will come with a microphone. That makes it interactive. So I put here behind us some potential possibilities for endoscopic frontal sinus surgery. It can be inflammatory or mucoceles or tumors or CSF leaks, etc. And we can ask ourselves these questions. Do we operate? What would be the optimal approach? The extent of the surgery? And probably, hopefully, we can also discuss the things we learned didn't work, because that's probably also very important, and the perioperative measures. I would like to introduce the panel to you, and for the panelists, the number you have on that slide is the same, is the order of which I put the cases, so then you know when to get nervous. The first one is Professor Nobuyoshi Otori from Japan, Professor Richard Harvey from Sydney, Professor Cem Meco from Turkey, Professor Brent Senior from the USA, Professor Alobid from Barcelona, and Professor Sama from Nottingham. They all do lots of frontal sinus surgery. I know that from a long time, and I'm really curious to hear what they're saying. Nobuyoshi, would you like to go to that microphone, or do you stay here?
Stay here.
Okay.
I give you. Me to... I go there.
No, whatever you like. I'm fine here. I'm absolutely fine. But then, Nobuyoshi, take the slides. Oops, back.
Okay, so this is my case, and as you see, the patient is a 39 years old male. It's a cool man, okay? And complaint that the patient is a severe headache only when the airplane descended, but otherwise he feels nothing. Okay? When I see him and I ask him that, what is your complaint? He only told me that only the severe head pain, only when he ride on the airplane and during descending, headache, but otherwise nothing. So the question is, should we operate him or not?
Okay, panel. Isam, Brent, I start with you and then we go along the table. Would you operate him, yes or no?
Yes, I would.
Why?
Because they have chronic sinusitis and a benign appearing osteoma in the frontal recess.
Okay.
Totally agree.
Isam, you agree?
Yeah.
Anshul?
Yes, I'd agree. There's disease past the osteoma, so the osteoma is obstructive, and I think he would benefit by having that removed for the front.
Richard, if he never flies, would you operate him?
Yeah, no, I was just about to say that, because the fact that he flies, I don't care what the scan looks like. Because he gets pain on the descent, he gets an operation, I'm going to tell him, I'm going to cure you. But if he came to me and he said, I've got terrible forehead pressure throughout most of the day, it's every day, I would actually then start to do things to prove, is it the sinus disease? And that phenomenon with flying makes all the difference, you know.
And if he flies once a year?
Yeah, and he gets a headache when he flies, and that's why he only flies once a year. No problems, you bet. I'll give him an operation and cure him for that, I think. Yeah.
Cem?
Yeah, it's also my feeling that they will fly. Flying is now more common, you know.
Yeah.
And the long we wait, it will be worse or it will not get better. I would go for operation.
would you think of wait and suppose he flies once a year? Would
Yeah.
you wait and scan?
Well, not so. He is not the frequent flyer, but I strongly recommend him to have surgical treatment because, once we do the operation to remove these two tumors, his feeling in terms of the head heaviness or head pain must definitely be improved. So even if he is a very asymptomatic patient, do the operation to improve the ventilation between frontal and ESMO, then the patient must feel okay, feel better. So, and together with if you see that he has a potent nasal septal deviation, but he feels no nasal blockage. But once we do the nasal septal surgery together, then his nasal breathing definitely will be improved. So even the patient is very much asymptomatic, we sometimes actively recommend the patient to have surgical treatment. This is my opinion.
Okay, what did you do? What did
Can
you
I
do?
can I ask a question before
sure.
we proceed? So the interesting question, that osteoma has been there for a long time. And the fact is that he's now presented, just to be a devil's advocate here, so he's presenting now with a symptom with pain on a singular event, was it single flight?
Yes.
So are we aware that did he have an upper respiratory tract infection before he started? He's got lots of inflammatory changes on the other sinuses, including the opposite frontal drainage pathways obstructed. Was he captured at a time that was just whilst he was recovering? And his actual anatomy right now looks different. So the question to ask is, would any of the panelists, if the situation was that he only had a singular event and had those signs and symptoms, would they ever think about giving him aggressive medical therapy and doing an interval scan later on?
I think I would do that.
Yeah. I think you're right in the fact that that's the option you could give him.
Yes.
But at 39, I would say to him, probably surgery is your best way of getting over these problems if you don't want them to come back again. Because really, if you give him a course of medical treatment, you probably have to say to him, you have to be very cautious at flying, because I agree with you. I look at this scan and think, it's not so much the osteoma, it's the fact that he's got a little bit of upper airway inflammation and he has an anatomically compromised area because of the osteoma. And so if he really doesn't have other signs of inflammatory airway disease, I think if he's going to have relief long term, it's still surgery. But a good point taken.
He's lived with that osteoma 20 years probably without significant problems. So
yes.
why do you feel that suddenly 39 is a crucial age?
Because
So
because this is very much chronic disease, very much the chronic disease. So the patient may be becoming familiar with the chronic head heaviness. So in that case, the patients tend to complain nothing. But if you operate to remove the tumor, that patient must definitely tell you that it's now I'm feeling it better. Yeah.
I think the other thing too is that when you go into it, whenever they get a cold, it's often more severe than what you would expect from a viral event. There's usually a bit more to it eventually in these stories. But you're right. For someone surgically adverse, giving them corticosteroids every time they fly or get a cold would be acceptable as well.
Can we ask the audience what they would do? Would you operate? Wait till you get a microphone. Otherwise.
And we should always say the conflict of interest that I'm a surgeon.
Okay, I've been.
The distinguished panel looks at the osteoma and ignores another pathology in the same frontal sinus. There is a Kuhn cell above the osteoma. So he has two problems in this same...
yeah, I agree. Yeah.
It changes a little bit towards surgery.
But would you operate?
Pardon?
Would you operate on him?
Yes.
Yes.
Definitely.
Okay. Who would operate in the audience?
So can I, Wytske, can I interrupt just for a second before you ask the crowd?
Yeah.
Because I'm going to be a little contrarian here, because I think this person deserves an operation regardless of whether the patient is getting pain with flying, regardless of whether, it's only once a year. Because in my opinion, that osteoma is only going to get larger with time. It's only going to become more of a challenge to remove when it starts invading his skull base or creeps up all along the skull base and then causes an acute Pott's puffy tumor 10 years, 15, 20 years, or 70, at age 70 when the patient has hypertension and has had a stroke, 6 months earlier. So I think this is a nice, easy procedure to accomplish at this stage in my hands. So in my opinion, this absolutely deserves an operation. So now that I've had a chance to express that, now I would like to see who would agree or disagree out in the audience.
Okay, but then I want to come back and say, if this doesn't grow, and it was a once-in-a-lifetime problem of flying just after a cold, with an osteoma that doesn't grow. And
how do you know it doesn't grow?
Wait. Make a scan for next year and in 5 years and in 10 years, and there's no grow at all.
Mm-hmm.
This probably is there already for 25 years. Why would you bother?
So,
with a chance of always a small risk, even in your magnificent surgical hands, whole panel, of a complication or a post-operative unfavorable outcome or whatever.
yeah, but I think now you have to have a patient who follows up, who will have to get repeated CT scans over a course of time to ensure that it's not growing.
That's true. Okay, we go to the audience.
We could say, Brent, if they were sitting on the fence, you could send them to myxrayrisk.com. Look up radiation exposure as a 39-year-old.
Yeah, is that from a lawyer or is that from a doctor?
It's actually patient support group, but that's the.
I can probably find a site on the lawyer side that would have different things to say about that.
Okay, raise your hand. Who would operate? Okay, who? Yeah, me too. But who? Who would not operate? Okay.
Wytske, can I ask?
I think you convinced them all, Brent.
Can I ask a question out of the panel? Who would think it's acceptable to do an operation and do a subtotal removal?
Unacceptable, in my opinion.
Yep, because I see that a lot.
Yeah, they
where
grow.
half it's removed. Now, the thing is that you cure the obstructive symptoms, but then I think a lot of the time you leave behind this raw osteoma that doesn't remucosalize and gets all sorts of problems. And,
unacceptable.
But 10 years ago, that was totally seemed acceptable, at least in Sydney, that people could have a subtotal resection. And then when you challenge them on it, it'd be like, well, I'm just running a risk-benefit balance for my patients. Maybe ask the audience or the panel.
Osteoma like this, so easy.
But it's the broad base on the posterior table.
Yeah.
I can actually see that as a possibility where I may leave a little tiny cuff on the back edge there to make sure that I don't get a CSF leak or something with it. So,
but you're talking near total resection.
Right? Oh yeah, absolutely. Yeah. I'm saying 95% or something. But I wouldn't be terribly afraid to leave a little tiny bit back there. But I agree with you. You don't want to leave, half of it or 3/4 of it or something like that.
Okay, let Nobuyoshi tell what he did.
I have not operated the patient yet because the operation will be settled in next month. I will operate the patient next month. But it's my plan is that because I should prevent any complication because he is no complaints, only expected head pain during descending. So I just asked the plastic surgeon to do the bicoronary incision because he's a cool guy. So think about the Killian approach or the bicoronary approach. We don't need to make an incision on his face. So I asked the plastic surgeon to do the bicoronary incision to expose the anterior wall of the frontal sinus and open the frontal sinus, remove it from the nose combination. So that's my plan. And also, I am going to do the nasal septoplasty. And if something happens, and if I want to cover the surface, the bony surface, I can use hemilateral nasal septal mucosa to just put on to prevent fibrosis or osteosis.
No, but I've seen you operate. I'm surprised you considering an external approach.
Yeah, external approach, the combination.
You don't want to do just a local?
Because maybe we need to have a certain space for, because this you see that the AP intermedia patient is not so small but not so wide enough. So if I start to remove the bone from the beneath, and if something just like a CSL happens, I cannot treat the patient. I'm not sure. So
I think you don't give yourself enough credit. I think you should be able to get it all endoscopically.
Who would go external? Who would say I can do this endoscopic? Cem.
I would definitely go endoscopic. So it's
Richard the same. I know. Anshul.
I would go endoscopic.
Endoscopic.
Yeah, endoscopic.
Brent. Okay. Nobuyoshi, you're on your own today.
But the question then to ask also is, if you're going to do it endoscopically, who would use a draft 2B and who would do a 3?
Good question.
So
Yeah,
how would you approach that? Would you feel that adequate to do a draft 2B, or do you think you have to do a 3?
3.
Got to do 3.
3.
It would be very difficult, I think, to reach that top when you do a 2B.
Even if you putzed around in a 2B and eventually got it out, the chances that that cavity would scar up would be super high. That'd be
for me again, it's that posterior table, and again, I just really want to be able to have good visualization of it as I'm drilling away on it.
Yeah.
And I find the 3 just helps me so much more. And you have a decent AP diameter there on the sagittal images, so I think a 3 would be my approach.
Isam?
I may start with 2B if I can remove it. If I can't, I remove the nasal septum of the upper part and do draft type 3. But we can start with 2B at least.
if you have a very talented plastic surgeon, that's very beautiful. One is very beautiful because not necessary to have a skin incision on his face. So after the operation, really cosmetically acceptable, I think.
Yeah, but it's not. It's the morbidity.
Mobility, yeah.
Morbidity is so much more than when you do endoscopic
Yeah,
procedure.
I think so.
It's this tiny thing.
I think you only have to see one osteoplastic flap die and someone get the morbidity of a dead bone flap from external craniotomy or frontal sinus surgery, then you realize that it's a fair bit of risk.
Okay, enough on this case. Let's move to the next one. Nobuyoshi, can you push it and give it to Richard?
Okay. I saw which case you picked. It's almost like the perfect lead-in to extending this whole thing. So this was a 44-year-old gentleman. He sells medical devices in Sydney, and he had a 6-month history of terrible forehead pressure. There might have been a little cold that preceded it. He had few other sinonasal symptoms. Very fit guy. He's a normal height at about 6'5", fit, and he was given a course of medical therapy, partial response, and then it came back. His only past history is that he had exostosis surgery 4 years previously, and he's really concerned because he's come along with a scan. He says, I never get headaches, and just in the last 6 months now I've had this sort of really forehead pressure. It goes away with medical treatment, comes back soon after. And this is what he has as a lesion.
So I missed his age. How old is he?
44. So he's got a large fibroosseous lesion. Do I ask the panel, does anyone want to chip in on?
Cem. We start on
Cem.
this side this time.
Okay. I mean,
and I should point out here, I haven't. He's also got an MRI that shows that there's a bit of T2 cerebral edema on his MRI scan. Did I include those pictures? I didn't send them to you.
No, I don't think so. Well, you could push the button, but I don't think there was an MRI. No.
no, and the patient had 4 years ago an exostosis surgery, and at that time, did he had any imaging or so? That would be interesting if it's.
He did. That's his imaging then.
Oh.
And
4 years ago.
And he saw Brent, who told him, "Don't worry about these. I don't operate."
Yet another reason not to operate.
I was not expecting that fast these images, but okay, now.
So this was 4 years previously. I actually went back and got the films, and this is a reconstruction from what were PTB studies, and for his exostosis. It was mentioned in the report, but no one mentioned it to him. So that's what it was 4 years previously. That's what it looks like.
Well, it definitely grew very fast, a little bit more unusual, actually, very, very fast. And there is an issue with the posterior wall of the frontal sinus that makes a pretty nice indentation, also expands in that way. Well, but the sinus is not that much.
What's your diagnosis anyway? What do you suspect is happening here?
Well, it has two portions. I mean, the upper part seems like a osteoma, but it could be an ossifying fibroma. You know, that would be my first fit, actually. It also explains the fast growth.
Yeah. Brent, any
No, yeah. To me, it's an ossifying fibroma, given the speed of growth and the variability and the character of the tumor on the CT scan as well.
He's a little old for that.
Yeah, he is,
admittedly,
but the speed is really what kind of grabs me, to be honest, and the aggressiveness also. The fact that it's kind of pushing back.
Yeah.
And then maybe just move on to Wytske.
Sure.
How would you remove it? Oh, so I'm not even going to ask. Does everyone surgery is required?
No, this is, yeah.
No, I would watch it.
Aggressive.
You'd watch it. You'd watch it.
Is there anybody from the panel that would not do operation?
I just like to say, when this was seen, the ENT surgeon, when I called him about it, thought it was so irrelevant that he didn't even mention it to the patient.
Yeah.
You can imagine how the patient felt when he represented like this.
Yeah.
What are you going to do?
Well, I personally again recommend to do the combined approach with the external approach and the endotracheal approach, because this is possible to remove the tumor with the endotracheal endoscopy approach, but it takes time, and you must have a certain amount of bleeding, so it's a tough job to do this, to remove it alone. So ask the other doctor to
you do
combined approach.
Wytske?
I would go endoscopically.
And why do you pick endoscopic though? Can I go back?
Because I think I can reach it all. There is a clear, there will be a clear mucosal layer also on most of that posterior part. And even if there is a tiny bit left in that, but I think I can get it out fully. And even if you go to the other slides, if you can't reach that very posterior part, that's acceptable. And I think I can get it out.
Brent,
So-
and then maybe we'll ask down the panel.
So with this case, I have evolved over the years. 20 years ago, I would do it entirely endoscopically. But I've become much more impatient as I've gotten older. And now I just want to get it done. And it would be 1/3 as long if I do an osteoplastic flap, so I'll do an osteoplastic flap. And I actually like that in this case because, again, I really want to be able to see that posterior table. I want to be able to be sure that I'm getting it clear of that posterior table. And also, if I get a little CSF leak, it's just a beautiful, easy exposure to repair that as well.
I would do the other way around, because 10 years ago or 15 years ago, I would be too impatient. Well, although the whole part looks quite soft, it's only that part that is very, but sometimes you have these very, very, very strong, very difficult to drill osteoma.
Yeah.
And then it took for ages. But now, with all the marvelous sharp
It is,
drills,
no doubt.
it goes so fast.
But the difference for me is that, I'll get a much bigger drill in there, and I'll actually even get my chisels in there, and I'll go to town, and it'll just be a much quicker procedure. But I understand. I have no problem doing it endoscopically.
Isam, what would you do?
Yeah. I may try endoscopically, draft type 3, but I'm worried about edema of frontal sinus. I prepare a patient just in case to do osteoplasty.
Yeah.
This should.
Maybe I start with draft type 3. If I can remove almost all the mass, I can go ahead with this. Otherwise, I go external approach.
And Anshul?
Brent, can I just clarify and just borrow your pen for a second? It's an osteoplastic flap, but not without obliteration.
No, definitely not obliterating.
Thank you.
Right.
So I would concur with Brent. I would prefer to go at this with a osteoplastic flap. The main concerns I have is often this component that we can only see the start of, the supraorbital component, that may be going further back and it's very close to the midline. And I like to be in control of the back wall when I'm taking this out. So my preferred route would be an osteoplastic flap.
Yep. And you know, I'm not. We'll go on to what I did. I mean, I'm not silly about it. You know, the reason I got these old scans was not out of curiosity, but was to see the attachment point. Mm-hmm. You know, the attachment point in my mind here, when I looked at it, it is the nasofrontal beak, very fortuitously for this man. Yeah. And my only thing is that when I do a Lothrop, I'd love to see normal sinus cavity. And so the fact that we've got a sort of an open left frontal meant that I did it endoscopically. And that's the morning after. And exactly as Wytske said, you know, because the attachment was the nasofrontal beak, as Wytske described it, there was just a shell of normal mucosa. Even the back wall had the...
Which is not infrequent, right? It's really interesting, actually, how you can have some of these really large bony tumors, and they still have that barrier there. Even though on the CT it looks like it's gone, you'll still find that little thin barrier.
I think you'd have to be convinced you could get to the attachment site,
absolutely.
Endoscopically. I think once you don't, then you've really got to consider doing it externally.
So what was the path?
Yeah, and the path was interesting. It's an osteoblastoma. Which is one of the differentials.
So it was good you had it out totally.
Yeah, and it's a great story of why, when you see an osteoma in the paranasal sinus, you must be very cautious of making a one-off judgment on a single point in time.
Yeah.
So can I poll the audience on the approach on this one?
Mm-hmm. Yes.
So who would do this entirely endoscopic? Raise your hand. Who would want to add an open approach? Most likely osteoplastic. Yeah. Interesting. Okay.
Yeah. Okay.
Good. Nice. Next.
Passing the pass.
Push.
You go next. You're up.
Cem.
Backwards.
So this was a 23-year-old attractive female, had headache mostly in the center of the forehead, sometimes on both sides, over the whole forehead, and complaints were intermittent since several months, so it's not continuous. She had a previous history of bilateral lobar turbinate surgery due to nasal breathing problems, which resolved after surgery. Otherwise, normal ENT findings, and had also very well pneumatized sinuses. But in these, you can see that they're on the right side, very lateral. There is a lesion, well circumscribed here, but her problems were really not fixed to one single point. So she was really telling that she had headache or forehead on bilateral. And this is the MRI of the same patient. It's very well circumscribed. And so the dilemma here is whether to operate or not. So it's a very well circumscribed and no bony erosion. And the symptoms are not correlated with the lesion. So sometimes bilateral, sometimes on the right side, sometimes only on the left side. So my question would be, what would you do in such a situation?
Who would like to comment?
You can start with your own, Brent, and work.
I'm sorry. Did you say there had been medical therapy already?
Yes.
Because I mean, it's interesting to me. The patient does have a little bit of maxillary disease, a little bit of ethmoid disease as well, in addition to this little thing. I just want to be sure that they've had appropriate medical therapy, because I'd be curious as to whether that little area might actually appear more normal after a long course of antibiotic and some steroids and things like that as well. I'd like to avoid going after it if I can, but if it continues to look like that, I would eventually end up doing surgery to look at that.
Where's her symptoms? What are they?
The symptoms are, headache, mostly in the center of the forehead, not even there.
Center of the
You
forehead.
know, and sometimes on both sides of the forehead. So the symptoms are really irrelevant. So, but during the checkup, you find something like that, and that's the question: how would you go further?
So yeah, so my point being that it's just really weird, and it doesn't correlate with the symptoms, but it's just not something that I would expect to see there. So I'd probably want to figure out what it is.
Okay.
Yeah.
Isam, what would you do?
Difficult case. At least I do surgery for this.
Sorry?
Surgery,
Surgery.
open approach.
Open approach. Okay. Anshul?
I'd be inclined to me, we're treating the patient rather than the scan. And I appreciate we found something unusual on that scan, and it raises concern, it raises curiosity. I know we've got some maxillary disease, but the osteomeatal complex doesn't look too bad. I would be very aggressive with the medical therapy, in my opinion, and I would probably observe that with a sequential scan. I'd be disinclined at the first consult or first presentation to actually intervene, because unless I see a change or progression in that pathology, or it's got nothing to do with the symptoms. And the patient is a young, attractive woman, as you said. So you are dealing with a precious commodity. You've got to be very careful what you do to this individual. You can't afford to leave them with scars or anything on their forehead that's not going to be very attractive at the end. So I'd be very cautious. I'd treat aggressively, very aggressively, with medical therapy, long-term antibiotics, topical steroid sprays, and then do a sequential scan maybe 6 months down the line.
Richard?
Yeah, so I sort of echo those sentiments. I look at this and think, okay, what is it? Is it something in the bone, or is it part of a compartment of the frontal sinus? Mm-hmm. And if you say that it's not in the bone, it's actually part of an old frontal sinus, you could explain the sort of neo-osteogenesis around the border as being, then maybe this is some area that underwent inflammation, and then there was chronic inflammation there. You've produced some chronic neo-osteogenesis. I don't think it's going to respond to medical therapy. We see this in the maxillary sinus all the time, and it doesn't cause terrible headaches. I'd be very dubious. And then when it comes to, like you see this in the frontal, when the whole frontal's involved, what are you going to do surgically? I think if you just break down the septum and connect it to the remaining frontal sinus, the scan will still look abnormal a year from now. And so you either remove this component. I'm just not convinced it's causing the pathology, and I don't think I could make the scan look so normal that it would advance her headache, the search for the cause of a headache either, with neurologists and other people.
It would bring you into a vicious circle.
I'd be part of the equation forevermore. Yeah.
Nobuyoshi?
Well, I don't know that whether the patient is single or get married, because 23 years old, it's exactly the same age as my daughter. So that is to say that the patient must don't want to have the surgical treatment. So need to first try to control with antibiotics or steroid potent medication first. Then if the patient finally really want to have the surgical treatment, then we have to think the complete removal, but we also have to think about the cosmetic aspect too, because it's a 23 female, it's very delicate.
Can I ask the panel, do you think it's inflammatory? And if you think it's inflammatory,
yes.
Do you think it will react to long-term medical treatment?
Well, I agree, yes. I think so, yes.
Yes? You don't think so, Richard?
No.
I don't think so.
No, because the neo-osteogenesis is like
Exactly.
a remodeling phenomenon. It's just a response to chronic low-grade inflammation in the sinus cavities. It's we should get over the fact that it's not bone infection or anything. No. But I can't imagine that even a short course of oral steroid that it would be corticosteroid responsive, because it's not acute inflammation. And so
I wouldn't
just
treat,
not gonna...
because if you start treating, then you acknowledge that there is disease.
Yeah.
And I don't think there is, I see an abnormality, but not disease.
You're treating the maxillary sinus, not giving them antibiotics for the lateral lesion. If you go to the CT scan, and it's interesting that between the CT and MRI, there has already been changes in the maxillary sinus. So if you look at the maxillary sinus, there is disease within the maxillary sinus. That is why I'm treating them with long-term antibiotics, is because I don't see any need for intervention for that either. The lateral lesion, I'm just going to observe sequentially. The medical treatment's not going to resolve that lateral lesion. The sequential scan will advise me as to what's happening with that. But the medical treatment is going to help with the maxillary disease, which may be the cause of their symptoms. We're trying to treat the patient. The patient's symptoms are bilateral and nasal bridge and frontal congestion. We know that the symptoms don't always localize to, as we would anticipate, to the sinuses they are. So I would still treat it medically for treating the symptoms.
So
Cem, what did you? Oh, okay. Brent?
just my concern though is that again, you're 100% right. We treat symptoms, we treat what, but this is weird, and it doesn't. I mean, obviously I understand knee osteogenesis and everything, but the point is we don't see knee osteogenesis anywhere else in this scan, and it's this weird isolated area way at the top. I'm just not 100% convinced it's inflammatory. Now again, maybe your patients in Australia or in the Netherlands follow up better than mine. But if I said, well, let's just watch it, that'll be the last time I see the patient, and I'll never be able to look at it again. So I just don't know what it is, and I always want to know what it is. I mean, I don't know. I feel uncomfortable just saying, well, it's probably inflammatory.
Can we go to the MR? We don't have the signal, do we? But is the post-contrast
We don't have
MR
contrast on that.
show enhancement through it or just in the rim?
Oh, that I cannot really.
Does everyone get that? If there was sort of rim enhancement of this lesion, I would say it's...
I'd be willing to look
I'd
at
be
that
happy
better.
to put my name against that and say it's inflammatory.
I'd be willing to do that.
But I think you're
this with
taking
the
you need an
information
MR.
we have.
Yeah, you need the MR to make that.
I mean, we were not also convinced that this was causing the symptoms, and we planned a scan in 6 months. And unfortunately, I've seen the patient, or the patient has been asked to me in Austria 5 months ago, so I don't have it right now. It's in 5th month, but the patient still, when we have given some nasal steroids and antibiotic treatment, but she has still the headache all over the head, but all over the head, not in that specific localization.
I think, though, in my opinion, if you're going to do any medical treatment, it's oral corticosteroid would be my one course of oral corticosteroid. If somehow it was magically responded to oral corticosteroid, then
Okay, perfect. But I mean, the symptoms were really not correlated with her the lesion. So and perhaps it's not even a lesion, but
Did you send it to the neurologist?
Yeah. Yes.
Okay.
But they haven't really done anything. Yeah. And actually, this was the case. And just to delineate this case, I have brought the scans of the other one. And this is a 39-year-old female with left frontal headache this time, very localized since 8 months. Had nasal obstruction, no history of any other systemic disease or operation. She's a smoker. And in the physical examination is septal deviation, otherwise normal findings. Neurologic examination revealed normal findings, and the cranial nerves are intact. And this time she has such a lesion. When that was actually the patient that I want to bring, but the other one came over that. So I just want to make an introduction with the other one. So in this one, there is some bonylytic lesions. So it's it's not like the other one. Also in the MRI, it has different enhancements, and this was for me clear that I need to go there and get some sample, and this is then the dilemma. Also, perhaps whether to operate or not to operate, but it was, for me clear due to the correlated lesions with the scans and symptoms. And then here comes the dilemma how to operate. External or endoscopic. Do we take only biopsy, or
Do you want to go back to the MR?
Yeah. MR, sorry.
The dural enhancement is what bothers me the most of that. Everyone see this down here on the far right? That's a lot of dural enhancement. Even, I think it's badness afoot.
But would that be a reason for you to only take a biopsy?
You bet. You bet. Yeah, that's exactly the reason.
Because you're not going to take this
I'm
out.
not going to make a decision about what definitively needs to happen here because
Exactly.
I'm blind.
Exactly.
Yeah.
Endoscopically?
No.
Open?
Open, yeah.
Why open? Why not endoscopic?
I'd
It's easy to reach?
I think it's really, it's a lot of work to get there, actually, in my opinion. And actually, I think just with an image-guided biopsy, you just drill straight down onto it. You make a tiny little incision, image guidance,
okay.
take a little kappa bone off, you can get a really good sample. If the procedure doesn't take long, you can hide the incision in the forehead crease or somewhere. They'll forgive you for it,
Nobuyoshi, what would you
Well,
do?
I think because the region is very much lateral, so I agree to do the biopsy to determine a diagnosis. But if CF leakage happens during the biopsy, then we need to have an external approach to close it because the region is too lateral. So if once the CS leakage happens, then it's really difficult to find out the location of the CS leakage, and it's also difficult to close it. So I do an external approach.
external
Yes,
approach?
right.
Isam?
For this patient, you mean? I do it endoscopically.
Endoscopically?
Yeah.
Okay. Brent?
Yeah, actually, I think I would probably biopsy endoscopically, expecting that I'm going to come back and do an open procedure for the actual definitive resection, but that would be with my neurosurgeon at that time.
Wytske, I'd just like to make a note, if you could record this moment in the panel where I'm doing something externally. And my colleagues are going to do a low drop
There's
to
a camera there,
biopsy
so it has been noted. Anshul, any comments?
Well, it's interesting. Can we just go back to the CT just for a minute? Sorry. Yeah, that dual enhancement is an issue, but I would approach it endoscopically through a draft 2B for a biopsy. I agree that the dual enhancement is concerning, and yes, I would be concerned about something unusual. But doing it endoscopically gives me the opportunity that if I just get a whole lot of sequestered pus, I'm doing the definitive procedure for the person at the same time. Whereas if I do it externally and I get that, then I would have had to have consented them for an endonasal procedure at the same time. But I appreciate your comments and concerns about the dura.
Okay, Cem, what did you do?
Well, actually, due to all the same reasons, I mean, the definitive surgery I would do externally. But the aim is to understand first what this is, and to get a biopsy. We have taken the endonasal route, and we also actually, I mean, let me go further. That's also, I don't know if it's playing. Can somebody play the video? Yeah, okay. And as we went there, you're gonna see now, that was really soft tissue that we have taken the biopsy, but it was really not attaching the bone that much, and it was really coming easily. And during the surgery, we decided to go further and to be able to go there and also drill the whole bone attached around. We have done orbital transposition or periorbital suspension. So we get the lamina papyracea out, introduce the brain spatula, the periorbita, and then by really...
It goes to show how a limited frontal approach would never get there. Don't you agree?
Yeah. So this is a draft type 3, yes. But I mean, during the course of the main intention was to get a biopsy, but all of a sudden we convert. I mean, naturally we have taken frozen section. That was not squamous cell carcinoma. and or another malignant disease, we drill till to the dura and the skin. Actually, and as much as, I mean, we didn't left any bone in that region, that we thought that it was the attachment point. So, and at the end, it came to be a histiostosis X, and then, surgically we were done, and then the patient was no more our patient, and they get a bone marrow biopsy, PET CT, and then she has had 2 chemotherapies.
And Wytske, can we just make on the record that the one time I didn't do a Lothrop, I was also correct? Is that, is that okay?
And this is the postoperative 1.5 year after the chemotherapy. It's very intact, and this is the endoscopy after 1.5 year. Can we also play the movie?
Yeah, they're there.
Okay, it's a little bit more narrow, but the opening is still nice. There are no inflammation, and
did you do anything to allow that cavity to mucosalize at all? I mean, you've removed all of that mucosa around. You've drilled that whole area. I would be really concerned it's just going to scar down and scar over everything.
Really not, because we didn't want to bring any. I mean, in this case, specific case, we haven't done. Yeah. This is it's natural healing. But actually, I'm doing for other inflammatory disease, or whenever I do the flaps. But at that time, 1.5 years ago, I didn't do that.
Cem, why did you go? I mean, it intrigues me that you actually went to remove the whole lesion with that dural enhancement. I would think there is something there, which is definitely more than just the frontal sinus, and I wouldn't be too bothered to take it out, but because I would feel there is something else anyway. But maybe that's so. What were your arguments to do that whole lateral transposition of the orbit, etc.? A lot of damage for something which had dural extension, so was not just something you would be able to get out.
Yeah, first, only by taking one punch or 2 punch of tissue, I thought that it might be inadequate. Then again, reaching that area, I mean, that's also for the intranasal tumors. Only, as you can see in the sorry, how can I go back? Yeah, to the MRI. So there are two different enhancements. Mm-hmm. If I get from the first and if the lesion is the second one, it would be inadequate sampling.
Yeah.
So I mean, once I go really to the bottom of it, then I see there the rest bone, and I'm already there.
Yeah.
It's then I'm the surgeon, as Dr. Harvey said. I mean, it was you don't try to. I mean, once you reach there, you don't want to leave something.
And you don't want to go back.
Yeah. But if I would have been coming in the frozen section, for example, a squamous cell carcinoma, I would stop at that point, and then I would go for a definitive external approach. But that was also not the case. So, I mean, that's the dilemma. That's the dilemma that you have during surgery. And
it's difficult to stop.
Yeah.
It's very difficult to stop. Yeah. Any more comments on this, Isam?
Yeah, going back to the first case, how do you convince the patient, his GP, and neurologist that there is nothing in this area?
Oh, yeah, that's what it is.
So this is the problem, but we face the patient every day or every 2 weeks. So how you convince him that this is nothing, this after maximum medical treatment? So.
Well, that patient is living in Austria, and in the Austrian system they are very well registered, and the primary ENT doctor is what I have done the residency together. So I mean, just before I came here to this panel, I called him and I let him ask the patient if she has still the symptoms, and that's the reason I'm saying after 5 months that she still have the overall headaches and problems. So it's very easy. I mean, in that system, it's very easy. But in Turkey, if they come from a rural area, then I would really not like the patient go far away. I would be more aggressive to understand what it is. So it's really...
Yeah, I agree with Isam that it can be very difficult to convince our colleagues from other departments that you see a lesion and that you're pretty sure that the lesion is not the cause of the headache. That can be an issue.
Yeah, but at some point, though, the patient has to either accept your professional opinion, because if they keep going and seeking out opinions, they'll find someone who says, "Oh, let's biopsy it, or let's operate on it," and then they just enter the whole equation of this girl's headache. You know, it becomes tricky, isn't it?
It's better for you not to be you.
Yeah, just not to be you. That's what I think.
Whoever picks up the knife is the one who takes responsibility for the patient's
So you have to
symptoms.
resist.
Yeah, I don't.
No
mind,
surgery, no surgery.
I don't mind losing the patient. I'd rather lose the patient than pick up my own headache. You know.
Okay, thank you very much, Cem. Really interesting cases. So we go to
Oh, it's me.
Brent.
Pass it down. Oh, so this is kind of the same thing, Wytske. Do we want to do this?
Yeah, well, yeah.
This is
well,
the
if
same-
If you think it's too similar,
Yeah, because again,
click
I guess
through.
we were all thinking the same thing on the panel when we submit our cases.
that's boring.
It's
Okay,
a-
just click through till the next.
Yeah, this
if you
is-
feel it's too much of the same.
This is more the same, more the same, more this. Keep going, keep going. Yeah, look at that. We went.
Very good case.
It's on. Very,
I
very
do
good.
have my other one on my presentation if they want to actually flip over.
Okay, okay.
But I don't know. Maybe we can do the next one and maybe they can pop
I
up
will
mine.
make sure that we do your other one at the end, somewhere before 15:15.
Okay.
For sure. Isam, go ahead.
Okay, this is 65 years old. He has nasal polyps, aspirin sensitivity, asthma. He had 2 previous surgery, and he presented us with exophthalmos, diplopia, and complete nasal obstruction and anosmia. So we can see. Let me go to make it fast. Maybe.
No control.
So you see that there is complete obstruction of nasal cavity. Oh. Hey, how does it work?
Yeah. No, it's-
Okay. All sinuses. If we see from axial and so you have
Okay, describe what you see for the audience.
yeah, this is complete opacification of sinuses. You see nasal polyps.
But remarkable sparing of the sphenoid mucosa relative to everything else.
Well,
which
that's the only place that's got some air, yeah.
More involvement of the nasal bones than there is of the
It's more than just air. There's actually thin mucosa in the sphenoid, which is why this is a local airway problem, not a disease secondary to broader immune problem.
So
Yeah.
this is the face of the patient that you see that something wrong. This I can't stop the
Yeah, there's a supraorbital mucocele on the right side, isn't there?
Yep.
yeah exactly. So I try to, but we can do. So in the CT scan we have big collection in this area. that it seemed like mucocele, but if we go to the surgery, see that the endoscopic view, you see.
So shall we stop it before and just talk about Samtes?
So I can
people's philosophy and how they manage
Sorry,
it.
I can't go back to the CT scan.
Keep going back one more. Go back one more.
One more, yeah.
Keep
One
clicking.
more.
Go back one more.
There you go.
Yeah.
Now go.
Forward one,
There you go.
and it should play now.
Okay. So this is the nice one. We can see now the septation in the frontal, right septal frontal sinus over there.
Yeah.
Like this area.
Yes, yes,
Yeah, you got it.
supraorbital.
Oh, okay. Comments
Okay.
from the audience or from the panel. What is your diagnosis? What would you do? Cem, what's your diagnosis?
It's a supraorbital mucocele.
Yeah. And what would you do?
I mean, surgery.
Yeah. And what kind of surgery?
I mean, I would do, in this patient, he has already operated 2 times earlier, and I would do a draft type 3, reach the supraorbital recess, and then drain the
The
mucocele.
mucocele. Yeah. And what is your argument to do it endoscopically? In what sort of situations would you go externally with such a mucocele?
Well, no. I mean, I would definitely first try to go and drain endoscopically, and if it's not reachable, that would be a cause.
Yeah, or you can't keep it open. Sometimes if it's very long and very narrow.
Yeah, but that you really appreciate during surgery. So my first try would be doing it endonasally, and you see it during surgery if you really think that it is again going to close. I mean, I can't see the. Exactly but there, it is very large, the supraorbital recess now due to the expansion of the mucocele. So actually the bone is also eroded in the so I mean I would try to reach the biggest possible opening, and for the draft type 3, I would introduce the flaps this time, as Dr. Senior has mentioned, so that it keeps as much as possible open.
Okay. Nobuyoshi?
Well, definitely, I first will try to manage with the endonasal approach. I will do the draft type 3, but because the structures in the vicinity of the nasofrontal duct has collapsed. So therefore, the window between the frontal mucocele and the small sinus can be still there in the future. I'm not sure. So I try to add the external approach to make sure that the communication between the frontal mucocele and small sinus will be permanently exist.
Okay.
Yeah.
Richard?
Well, you know what I do. This is an Australian special. You know, this is what I deal with all the time back home. You just create one giant open cavity with a lothrop. Everything is mucosally lined with the same diseased mucosa that it came with. And it's very different from tumour surgery. You can really get to all parts of the frontal where you're doing inflammatory disease. It's only when you have to drill out tumours that I think you run into issues with access. And then you treat them aggressively afterwards. And this is the sort of patient that I would leave on oral steroid for a long time after surgery. I'd really want their cavity to have healed well before I pull their oral steroid and leave them on a corticosteroid irrigation alone. So you'd want to get them well past the healing, graft or no grafts, to where you're happy.
Probably months. Huh?
Yeah, a couple of months would be, 6 to 8 weeks is sort of where we're headed with people with severe disease. And you might find that her asthma even warrants that for a short period. And reality is, someone said to me, oh, Richard, but that's so much steroid. If you treat patients this way, who have this condition, you actually narrow down their risk to giving them one procedure once, where you then expose them to an anaesthetic, an operation, and their perioperative corticosteroid use to one occasion. Whereas I think when you commit them to multiple procedures and they get multiple courses of oral steroid, you could potentially say that there's a case to be made just to do it all in one solid go.
Anshul, any other ideas?
No, I entirely agree. I think you 2 operations already. This is a condition you really have to be aggressive to open up. I would reduce the middle turbinates as well to get better access to the cavities. The disease, if it's going to come back, will come back in that anterior model frontal complex. So you really want that widely open. I'm not as aggressive as Richard on my oral steroids, but I'm very aggressive long term. So I will put them on Pulmicort for quite some time, topically in their douching, because I find that works quite well in long-term maintenance for these individuals. But surgically, I would agree entirely.
Brent?
So just one additional surgical point. I would definitely do all this endoscopically, of course. I would also do a draft 3, but I wouldn't have a problem for someone to say, well, we've got a big mucus seal. I'm afraid I won't be able to drain it effectively. What if I go external? That's fine, but what I would discourage, don't think that you're going to obliterate this cavity somehow, right? Because the bone is absent all over the eye there. You're never going to get all that mucosa out to protect the eye. It's just going to form a mucus seal in the future. So if you do an external approach, a brow incision or something, you've got to communicate it into the nose and open that mucus seal really well into the nose. That's just something I would throw out. Otherwise, I don't disagree with anything in terms of the management. The only other thing I would add is there may be a role for aspirin desensitization in this particular case as well. I'm not a huge fan of it, but I think the data is fairly compelling when it's done well, and this might be a situation, given how severe his polyps and his mucoseals are, to consider it.
That's after surgery?
After surgery, correct. We would do the surgery, then do the aspirin desensitization.
Okay,
so my question to the panel, is this mucus or
Well, we
polyps?
don't know, because
in the
normally-
in the frontal sinus, you see.
Right.
It could be either.
It could be. So normally with that dehiscence, I would always follow up with an MRI scan.
I would also.
So if
Yeah.
you've got dehiscence involving the orbit of the cranial cavity, you need an MRI.
You ask always for MRI in these cases?
I would.
I do.
I must admit, I'm going to say I don't, because I think the diagnosis is pretty much the same here. It looks benign. Even if you can see the bones all depressed. I'm happy to do this without an MRI, because no matter what the differentials are there, I'm still going to be able to probably manage it.
Yeah, it's
through the treatment.
mucus or
Could be
polyps.
mucocele, polyps, even if you've kind of papilloma
the same procedure.
it's all the same thing.
Okay.
If you got a surprise, you're not going to change what you're doing.
Just in case if I did it wrong or not.
Yeah.
So,
I would just also throw out that I would send this patient over for an ophthalmology exam before I did surgery as well. I think
Why?
that's because I need confirmation that the patient has diplopia, has issues with extraocular movements, which is obvious here, but I want that confirmed in writing, because when he wakes up and he has problems with his vision and extraocular movements, I don't want it be blamed on me.
yeah.
I would tell him that the chance that he would have double vision after the surgery is really possible.
Yeah, I agree with that. And that's something I want.
Go after a few days.
Excellent point, and that's absolutely what I would tell them as well. And that's a really important point for preoperative counseling. Even if they didn't have diplopia, it's a slow-growing process, so sometimes patients accommodate to this, but they probably will have diplopia after surgery, absolutely.
So in fact, this patient was referred from ophthalmologist because
Perfect.
he went first to the ophthalmologist and came to us. So This is, you want to say that? Okay.
What is that too?
So that's
That's the patient?
Yeah, pre-op.
Sorry?
Pre-op.
Oh, a question. Marvelous. Go ahead. Go ahead.
I've been listening to this and I wonder, why haven't you mentioned his teeth? He has lots of infections, periapical osteoarthritis around mostly the few teeth he has left. And I'm sure that will secure that he has a maxillary sinusitis, an infectious one. And if you're going to keep him on oral steroids for a long period, you should really treat his teeth. You haven't mentioned it. I'm a bit surprised.
Do periapical lucencies on the teeth?
Apical periodontitis on most of his teeth. If you look at the CT scan, you see it very easily.
So
All
is it
Both
neosteogenesis of the tooth roots?
No, it's infection on those teeth in his upper jaw on both sides. Just look at the pictures.
Because if it's neoosteogenesis and wait for it to come up, bone thickening, I don't see that as being...
I think you really should treat it. Look at these molars. Lots of periodontitis apical on the end of the roots on both sides. And it's very close. If you look in this area, you can see it very easily. It's communicating with the maxillary sinus. That's very important to treat that as well.
I think that's an excellent point. I didn't notice that on the film. I think you're exactly right. We got to be careful about that. Now, obviously, it's not his teeth that's causing all of this problem, but it's going to be just one component of his whole disease process that we should be managing.
Yeah, and it's a good point, like if they're diabetic as well, you got to forewarn them that, listen, you're going to have to change your insulin regime or whatever during this.
Yeah, that's actually a great question. What would you do if he were diabetic?
No difference. Just have to change.
You would still keep him on the steroids?
Yeah, and you just give their endocrinologist involved and they just have to change their diabetic management.
So you guys have better care in Australia.
Yeah.
Endocrinologist, what is that?
Very, very good comment. Any other people who want to comment?
I would like to say that I would never operate prior doing an MRI.
Yeah.
Always, in this case, specifically because we have such a nice situation in sphenoid, which is not something that we see so often. So I would always do an MRI and then see, I'm not sure that this is a mucocele. It looks typical, but it doesn't have to be. So it would be an MRI, and then I would proceed, and I would ask you, how would you explain such a nice situation in sphenoid, and how often do you see that with recurrent polyposis?
Does this change your procedure?
MRI would definitely...
You have to back it up, though. If you say you would never do it without the MRI, you have to say, which condition are you searching for that's going to change your opinion in that?
It might be a tumor, why not?
Yeah, but then it's got the bone intact and it's just benign distortion of the things. What are you going to do differently?
I didn't see an intact bone. There was a...
I think it is a wise thing to suggest that when you have orbital dehiscence, a big area of orbital dehiscence, you have skull-based dehiscence or something like that. I mean, I also would get an MRI, and I do think that's an important point. But I also understand exactly what you're saying, Richard.
Let's ask the audience.
Yeah, I'm just cautious about making standards.
Yeah, no, I agree.
We criticise a colleague who doesn't do it. Because I think if you've got to say it's absolutely mandatory, well, why is it absolutely mandatory, you know?
Yeah.
Tell me. I mean, one of the reasons, and that's obviously a great point, but one of the reasons I do it is it's just more information for me to understand the disease process. It's not going to necessarily change what I do, but it helps me understand what I'm getting myself into when I do the operation. That's the reason I do it.
Okay, who from the audience would do an MRI? Thank you very much. Who would not do an MRI?
No, we should ask the audience who thinks it's mandatory to do an MRI.
Oh, yeah, okay.
Because because we're about to put a standard up on our other colleagues.
That's good.
Yeah, that's a good question.
Who thinks it's mandatory?
Who thinks it's mandatory to do an MRI? You have to have an MRI.
You've got to stand up in court and say it was totally inappropriate to not do an MRI scan.
Okay.
Yeah.
Who can live with Richard not doing an MRI?
Yes, and naysayers.
So we have two previous surgery.
Go on.
Yeah.
What did you do? What did you find?
I go to surgery, This is complete obstruction of both sides. I did draft type 3. I tried to do what Meco showed us to remove the papyracea, but I failed to do it by myself. You see, this is the difference between mucus. I totally agree with Richard. This is polyps inside the frontal sinus. Edema, polyps. I remove everything, but I failed to remove the papyracea in what we saw in the CT scan. But turning the 45 degree, I can see that the orbit. Let me see if I can. So in the corner at 10 o'clock, you see.
Yep.
I remove everything. So the patient is happy. He has no diplopia. He smells very well. And I was very happy also. So I go to do a CT scan to document my case. So.
Bad idea.
Uh-oh.
Bad idea.
This is the situation. We can jump to more.
What medical?
Three months.
What medical treatment do you have him on?
Intranasal steroids.
Just what spray?
Spray. Drops. We have drops. Fluticasone.
In my experience, if you have someone like that bad disease, just on some drops, that's never going to work. You know, it's never going to control.
This is 3 months after surgery.
Yeah.
So that's the reason for long-term systemic steroids.
So the key thing there is you've got air.
Exactly.
In that mucocele. So that's telling us that you aren't adequately treating the mucosal disease. So it's not a surgical problem any longer.
It's a surgical success.
It's a mucosal, because you've got air in that lateral mucocele, lateral aspect. So you drained it, you just got to be more aggressive with your medical therapy before you scan them.
Yeah, it's a surgical success.
So it's a bad idea to ask for CT scan.
Not before, yeah.
So in this case, I go to maximum corticosteroid therapy oral for long term.
Yeah.
No, so the oral steroid is only during the period perioperatively, because you've got to get him through the raw bone, the trauma of the surgery, the fact that you've added inflammation to an already inflamed sinus cavity. Long term, they need corticosteroid irrigation, something that's actually going to get into those far reaches. You know.
At this stage, would you not use orals?
Oh, yeah. No, it depends. It's very tricky now, isn't it? Because with 3 months out, you've missed the window of healing, and then they're pretty asymptomatic. Is that correct?
Exactly.
Yeah, I'd probably just put them on steroid irrigation. Unless I looked with the endoscope and things were so swollen that I don't think this steroid irrigation would get into parts of the frontal sinus. And then I'd give them, of course, the oral steroid to kick them off, you know.
I would be willing to expect that you would get a really nice effect even with oral steroids at this point. Yeah. Even though we're 3 months out, I think that you would. And I absolutely agree with what Richard is saying. I think it's really, really important to try to get those membranes as normalized as possible. So I'm super aggressive in those first few months after surgery, trying all my medical therapies to try to keep that and get that cavity healed up. It's like I'm trying to sort of reset the inflammatory cascades to sort of forget what it was like to be overreactive previously and now keep it nice and calm, even though I'm giving it a crutch to do that.
Reboot up to
Rebooting the system, yeah. But then what I tend to rely on, I really do try to get them off the orals as quickly as possible, and I'll double, triple dose topicals and drops with irrigations, and I'll go with the topicals at super, relatively speaking, high doses, because I still think it's probably in the long term safer than being on the long term orals.
So I think you should do a shout out here, Brent, because I think you published that paper with Kennedy that showed that the biggest prognostic factor was the state of the mucosa in their first post-op visit there.
Yeah,
I mean, everyone talks about rebooting now, but that was your paper from 15 years ago or something like that.
Yeah. No, that's exactly right, and And that's really what I learned in fellowship, is that we just had to get that stuff normalized, get that mucosa
early on.
as early as possible.
And I agree, that's been my marker of success, when they come back in the first 3 months and they're normal.
Maximum,
We had a question from the audience.
Thank you. We discussed mostly about the post-operative oral steroids. Do you think there's a place to administer them pre-operatively, and what kind of period would you suggest to do it?
So, when we go to the OR, I did the maximum medical treatment for at least 1 month before surgery, doing CT scan, ophthalmologist, the pre-op, and he does maximum antibiotic and steroid for at least 2 weeks before surgery.
Steroid tablets or drops?
No, oral.
Oral steroids.
Yeah, oral steroid, yeah.
So I personally would give him steroids ahead of the operation, but usually, honestly, for just a few days ahead of the operation. And really, I've learned, for me personally, the reason I'm doing that is more to keep his lungs healthy during a long operation, because this is going to be a long operation in my hands. It's going to take me several hours to get that nice and cleaned out. And I really want his lungs to be, because he's a Samter's triad patient, he's got asthma, he's gonna react negatively to all the drainage and what have you. So I'll do that to keep his lungs as healthy as possible, and then taper him down post-op.
Yes, go ahead. One after another. Please.
Philippe, you want to start?
Go ahead.
Would it be a good idea or helpful to be a bit more aggressive during primary surgery? I mean, I would shave all polypoid mucosa off the frontal sinus during the first operation. Would you feel that this would be a good idea?
So this is not my patient. They referred him to our department because the previous surgery done in another center. We usually use aggressive surgery, extended surgery for Samter disease in order to remove the mucosa. But in these cases, violent inflammatory disease, it's difficult to remove everything because you can't remove every mucosa of the nose.
So that's a very interesting question. I think I'll put it to the panel as to at what stage do they strip mucosa from the frontal and ethmoidal and maxillary sinuses in these cases? And if they do, at what stage do they consider that an acceptable strategy to have?
Any other comments from
I think if I could have an MRI image before the operation, that if I could confirm the polyp inside, then try to give the steroid before the operation potently, okay? Then, but during the operation, if you try to remove all pathology from sinus cavities, you may expose bony surface. Then you might have a mucosal, secondary mucosal in the future. So I don't want to try to remove all, but I just want to do the maximal surface removal with the potent steroid oral therapy after the operation. That's my plan.
Cem, any comments? Yeah, you agree? Okay. Philippe.
3 small questions. The first is, in this case, you give the postoperative systemic steroids. How long does it mean? That's 2 weeks, 3 weeks, 4 weeks? And at which dosage? The second is there any indication to combine systemic steroids and doxycycline in the postoperative? And the last thing is that we have not so good experience with topical steroids in lavage. So what does it mean? Maybe we have not the appropriate dosage, or how much there's a need, so on, do you put in your lavage?
Who wants to comment on that?
So I absolutely would also add either macrolide or doxycycline to my regimen post-operatively. I typically will do that for 1 month in a situation like this. I do feel it's a little bit synergistic. Again, that's just my gestalt. I don't have great evidence for that. So I do that. You bring up a good point, though, about the
topical steroid in the rinse and what have you. And I do think it's important, and in fact, we have published on the fact that if you get the wrong dose, you won't get much of an effect. So I do think you have to have a reasonable dose in your rinse in order to get an effect to be seen. And so in our case, we will go with a 0.5 of budesonide in the rinse and be rinsing with that twice daily, actually. So they're getting 1 milligram of budesonide a day to get an effect.
Richard, how much do you give in the saline?
I use very similar. In 240 mils, they get I get 1 milligram though in one wash once a day. I must admit, I don't have people do it more than once a day. My experience is that if you get control on once a day, then you get control on once a day. Those who fail in aspirin-sensitive disease are going to fail whether you get them 2, 3, 4 times a day. That would be my feeling. And for oral steroid, I do give oral steroid for a long time, but I don't give big doses. So if you're a 70 kilogram person, would only get a 25 milligram dose. And there's good evidence to show that that's enough to suppress eosinophil activity, which is what we're trying to do here. Only in bigger people do I give them up to 40 milligrams. And then they go usually on a tapering dose, somewhere between 3 weeks and 6 weeks for most.
I really taper till very low. Sometimes these people, if you just keep them say, I taper to 5 milligram a day and then 5 milligram every other day and even twice a week. And the funny thing is that many of these people keep smelling and the mucosa keeps very well on such very, very low doses, like twice a week, 5 milligrams is really nothing. And as soon as you stop that, boom, the mucosa starts again to grow. So I'm a big fan of that. And we have a presentation here, Evelien Larijse will give that. We looked at DEXA scans of quite a large group of patients with nasal polyps who had quite often systemic steroid and compared that to the normal population and didn't make any difference. So I think we are quite worried because normally the big databases looking at steroid use are always patients who needed steroid either on a daily basis for a long period of years or they had another disease which gives them a higher chance of having osteoporosis. So I think looking at that data, we don't have to be that afraid of giving a few months of relatively low-dose systemic steroids.
Are you referring to the BMJ article, that epidemiologic article that looked at one course of oral steroids, suggested you had a fracture risk?
Yeah, exactly. Yeah. But that's because that's all piled together. So in that analysis are also the patients that used 30 milligrams for the last 10 years. And of course, then over the average population, yes, there is an increased risk. But if we purely for polyps, at least in the DEXA scan study we did now, it's about 100 patients, we didn't see any difference. So I'm less worried than I was before.
My only caution with that would be to remember to think about other sources of steroid the patient may be getting. And again, a lot of these patients have bad lung disease, so they might be on high doses of inhaled steroids, which are very active systemically. So don't forget that while you're remembering that it can be safe to give those courses of orals that Wytske is talking about. Be sure that you're remembering the fact they could have inhaled steroid as well.
Guys, we have 7 minutes left. Do we want a quickie and then it should be Anshul or Brent, or do we?
No, yeah, done.
Mm-hmm. What does the audience want to do? Want to look at another case, or does the audience have particular questions they'd like to raise?
Yeah, that's also a very good option.
Lewin has a question in the front here.
Yep.
More questions and discussions, probably useful. Just wait till you get a microphone, please. Otherwise, people can't hear you.
I'd like to ask the panel about the case of histiocytosis. Can you approach a small incision with IGS and take a biopsy and then turn out to be the histiocytosis, the chemotherapy can help without any surgery. Thank you.
Yeah, I think that was what Richard Harvey suggested.
Yep.
Just take a small biopsy, and then the diagnosis would lead you to a totally different treatment, and the surgical treatment is not necessary.
But, and they would have been left with a small incision on their forehead, admittedly. 7 mils, maybe up to 10 mils, where I did a directed biopsy.
Yeah, there's certain conditions where best not to operate, Well, any other questions, or shall we discuss this one? So I think this brings up several different factors, which is interesting. This patient presented originally from another unit, having presented with a frontal swelling, was treated with IV antibiotics, settled down, then represented 6 months later with another swelling, and then hence was referred over to us. And if you can see here on the scan, sorry, is that not working?
It's working.
Thank you very much. It is. So you can see that there is a dehiscence. You can see that there is swelling associated, and there is obviously quite a lot of neosteogenesis occurring in these scans. But on the other side, we've also got an interesting pathology in that we've got an obstructive frontoethmoidal cell with the frontal sinus itself is lateralized. So the questions really to look at is, in this situation where you've got, how would the panel consider management of acute osteomyelitis when it presents with frontal swelling and a scan like that? Would you treat with IV antibiotics? Would you do anything surgically other than treating with IV antibiotics? Brent, you seem to have the short straw. You're sitting on the wrong
side.
Is it acute or chronic? It's chronic. It's chronic osteomyelitis. Recurrent. But over many, many months.
So it's chronic. Occurred on 2 occasions. It presented about 3 months ago, treated the IV antibiotics, settled down, and then recurred.
It's chronic.
Yeah, chronic.
Yeah, I always hate to see all that new bone in the frontal sinus when I'm thinking about surgery to try to manage it. And this is a typical situation when you've had chronic osteo or recurrent bouts of osteo to see that type of neoosteogenesis occurring. My sense is because it is recurrent, I probably would elect to do surgery. The point of the surgery is to make sure that any little fluid collections there are managed as well as possible so they're not little mucoceles that are going to continue to fester on. I don't intend to remove all of that new bone. So it's because that's kind of hopeless in my experience. I find that new bone is just going to recur a couple months later. It's going to, once that neoosteogenesis seems to kick in, I don't know, is that experience that others have? Because I just seem to, I've drilled it, I've cleaned it all out, and it just seems to want to come back.
Well, I think that is the key thing, is how do we all deal with this very difficult entity of osteitis, neoosteogenesis, whatever you call.
Because the question you have to ask yourself, what is going on here? Like, why does it keep recurring? And there's osteomyelitis, but why did it start in the first place? I agree with Brent. It's all the trapped mucosa. Yeah. And so I do take them to theatre. I do drill everything out, and I put a PICC line in at that time. Yeah, so that's the time I start their long term. And I completely agree with you, Brent. I think sometimes they self-obliterate and it collapses down, but at least I feel like maybe I've drilled out the nidus or the source.
The evil humors. Yeah. It's like bleeding. It's like bleeding a patient. That's right.
Would anybody do anything different or have a different strategy for managing this kind of neosteogenesis, which is obstructive? Cem?
No, actually, it's the same. I mean, these small entrapped mucosa should be opened, actually, but then it will after the IV antibiotics, and then as Dr. Senior mentioned, it's really hopeless. It will come back again, but not in a way that the mucosa will be trapped. So it will narrow itself. It will self-obliterate, let's say, the frontal sinus.
Hopefully.
Lucky.
Hopefully.
Lucky.
So let's ask the panel which way would they approach this. Would they approach this endonasally? It's bilateral disease, so it's fair dues to consider draft 3 because you've got a type 3-4 cell on the opposite side, a lateral obstructed frontal sinus on the right, and then a mucocele quite high up with lots of bone in between. how would you approach it? So let's start from this side, if I may.
Well, I think that because the osteogenesis looks very evident, so if I, do the draft type 3, it's okay, it's possible, but after operation, it's hard to control the new osteogenesis. So why not you try to do the external approach to remove all and ask the plastic surgeon to again reconstruct the anterior face of a frontal sinus to keep his outer shape of the face.
So you would reconstruct that dehiscence? How would you reconstruct it? What would you reconstruct?
Ask the plastic surgeon to use the other part of the frontal bone to take it out and take out the other part of the frontal head bone to thin it.
You'll take the external plate off and then use it.
Yes.
Would you do anything different, Richard?
Yeah, no, I wouldn't touch it in terms of putting hardware in or free bone grafts or anything. Brad Woodworth and I published a paper to show that big anterior wall defects in mucoceles of the frontal sinus, you just leave them.
Yep.
And if the periosteum's intact, you rarely get a cosmetic defect. I mean, and they're the sort of cases where we did all endoscopic. We just let that huge anterior dehiscence collapse in.
Yeah.
And not one of them over time gave them a defect. And I think the minute you introduce foreign material plating, it just adds that extra factor that could cause a problem.
Yeah, it's a very valid point, because a lot of the dehiscence we often see in the posterior wall, anterior wall, orbital wall, if you ever happen to scan them later on, you find new bone has formed in that area because... would you do anything different? Nope. Brent? Would you approach it endoscopically or open?
So I would definitely start out with everything endoscopically and drill as much. I do have a little concern about that one little pocket as to whether I'd be able to get up there and really open it and clean it the way that I would want. And in that case, I have occasionally combined it with a simple incision either at the brow and then just directly entering the area. And if it's filled with new bone, then I'll literally just drill out the little pocket and just obliterate the little tiny cavity right there, knowing that it's not going to communicate directly with the frontal, or keeping it from directly communicating with the frontal.
Okay, Anshul, so show what you did, because time is up for us.
Well, I did an open approach, and I drilled all the bone off, which is what I like to do with these neosteogenesis, and I do obviously an endoscopic draft 3 at the same time to establish drainage. This is what you normally see, is all this new bone that forms. It's this kind of thick, fragmented bone. In my impression, it's actually drilling that off is what's going to get you to be able to get a cavity. You are going to get fibrosis. You're not going to get a beautifully mucosal lined cavity, but you're going to have all the areas draining, which is your ultimate aim. So I approached it with an open. I just feel more comfortable drilling those bits off with an open approach.
Okay, thank you very much, panel, for this